Welcome to This Explainer. Today, we're diving straight into a totally fascinating roundtable report from Femtechnology that completely reframes how we look at women's health. For decades, we've treated this as just a niche biological issue, something siloed away in specific medical departments. But what if it's actually a massive, solvable design failure? Today, we're exploring an architecture of health that is fundamentally structurally flawed. And more importantly, we're going to lay out the exact action framework we need to finally fix it. Right out of the gate, we're hit with a pretty shocking reality. Think about these numbers across 27 OECD nations. For every $100 a health system invests in a man's health, it gets back about 2.62 months of life. But for a woman, that exact same $100 investment buys only 1.56 months. Women are getting significantly less life back for the exact same system expenditure. It's honestly a staggering discrepancy. So here's the absolute crucial takeaway. This 40% gap. It is not a fact of biology. Let me repeat that. It is not biological. It's a structural penalty. Women are walking into a medical, financial, and pharmaceutical system that simply wasn't built for them. The diagnostic protocols, the drug dosing, the screening guidelines, all of it was drafted with a totally different default user in mind. And this 40% gap is basically the compounding cost of that mismatch. To really dismantle how this architecture works, we're going to quickly walk through 6 key areas. A system built for men, mandating the data and governance, diagnostic delays in clinics, the innovation desert in pharma, repricing risk and finance, and finally, unlocking a trillion-dollar solution. Let's get into it. Starting off with Section 1, a system built for men, and understanding the underlying architectural flaw. The core issue we're dealing with here is what's called an architectural flaw. For literal centuries, male physiology has been treated as the unmarked default for human biology. Because the baseline for everything, from how clinical trials are run to how modern AI training sets are built, just automatically defaults to male biology, women experience this continuous, compounding mismatch. And this isn't just about feeling ignored at the doctor's office. This silently snowballs into massive systemic costs. We're talking emergency room admissions, early retirements, and disability claims that society and taxpayers end up paying for, usually without ever realizing why the system failed in the first place. Moving right along to Section 2, governance, mandating the data and moving way beyond just simple recommendations. This is exactly why leaders like California's Surgeon General, for example, are pushing so hard to mandate data tracking. Take a pregnancy complication like preeclampsia. Usually it's treated as an isolated reproductive event. But it's not. It is actually a highly predictive window into a woman's lifelong cardiovascular risk. If there's a missed postpartum follow-up, she carries a 2 to 4 times higher lifetime risk of cardiovascular disease. And by the time it's finally caught, it's an avoidable late-stage crisis. Mandating data tracking links that initial complication to lifelong monitoring, which catches the real risk decades earlier. Now, this is where governance actually gets some teeth. By legally mandating sex-disaggregated data across national registries, basically forcing the data to be tracked by sex, countries like Finland are doing something truly revolutionary. They aren't just making polite recommendations anymore, they've set concrete time-bound targets. Specifically, they've set a Nordic parity target to actually close the gap in healthy life years between men and women by 2040. They're proving that when you legally require the data, you can actually build the infrastructure to solve the problem. Okay, Section 3, clinics. The diagnostic delay, and what we call the infrastructure of missed diagnosis. Think about the massive gap on a typical healthcare timeline between when a woman's biological risk actually begins and when clinical screening is finally authorized and paid for by the system. Bone health starts declining around age 45. Menopause symptoms peak at 50, bringing a whole host of secondary risks, including a sharp acceleration in cardiovascular risk around 55. Yet, osteoporosis screening isn't typically covered until age 65. That is a 20-year gap where biological reality is completely out of sync with clinical guidelines. And because these screening guidelines lag so aggressively behind reality, and because medical specialties often operate in totally disconnected silos, treating isolated symptoms instead of systemic mechanisms, the result is honestly devastating. Women face an average diagnostic delay of 4 entire years. And that's not just for a couple of obscure conditions. That is the average delay across over 700 different diseases. Just think about that. 4 years of missed interventions. Which brings us to Section 4, pharma, the innovation desert and the problem of building on an incomplete foundation. The sheer vastness of this innovation desert is staggering. Women make up literally 100% of the female patient population. They're all interacting with the healthcare system. Yet when you break down the actual investments, only 4% of pharmaceutical R&D pipelines focus on female-specific conditions. And it gets worse. Only 4% of drug labels include sex-specific dosing instructions. Despite suffering adverse drug reactions at nearly twice the rate of men, women are shockingly underrepresented in the very research that's supposed to heal them. There's this fantastic quote from a pharmaceutical general manager that perfectly captures a much-needed paradigm shift. They said, "Stop counting the cost of treating women and start counting the cost of ignoring them." This powerful shift in perspective demands that health economic evaluations finally wake up. They need to include the massive, invisible, indirect costs of women leaving the workforce, losing caregiving capacity, and accumulating preventable illnesses due to undertreated conditions. When you actually count the cost of ignoring the problem, the business case for investing in women's health changes overnight. Now on to Section 5, Finance, repricing the risk and understanding this compounding penalty. Here we see what's known as the bias tax in action. It's basically this vicious self-reinforcing cycle. Remember that diagnostic delay we just talked about? Well, because diagnosis is delayed, women often present at a later, more severe stage of a disease. This naturally causes a huge spike in expensive emergency claims. Actuarial models look at that data, see the spikes, and tag women as high risk. The result? Higher insurance premiums. The system is literally penalizing women financially for the system's own failure to diagnose them on time. It's charging them more for receiving worse care. And we really have to understand that this isn't just a health crisis, it's a compounding financial penalty. It literally drains women's wealth over a lifetime. You start with the gender wage gap, then add an 18 to 30% higher out-of-pocket medical costs. Factor in early health-driven exits from the workforce, very often during peak earning years, because of undertreated conditions like menopause or endometriosis. The terrifying result is a 30 to 40% smaller pension savings at retirement. This exact cascade is why 2/3 of global pensioners living in poverty are women. But, there is an incredible opportunity hidden in all this. As one reinsurance leader pointed out, insurance doesn't own care delivery, but it owns the long view. By shifting the model away from risk pricing, where we just charge more for expected decline, and moving toward risk prevention, insurers have a massive financial incentive to fund early detection. Why? Because healthier, longer-living policyholders benefit the entire financial chain. Catching disease early is quite simply better business. All right, let's bring it all together in Section 6, Unlocking the Trillion-Dollar Solution, the Master Key. When you lay out how these sectors interact, it reveals the ultimate systemic standoff. Every single sector, government, pharma, clinics, and finance, holds a crucial piece of the puzzle. And the crazy part is, they're all acting entirely rationally. But they're all waiting for someone else to make the first move. Government is waiting for economic evidence. Farmers waiting for market-size proof. Clinics are waiting for updated guidelines. And finance is waiting for de-risked proof. They are completely gridlocked. So how do we actually break this gridlock? We need a master key. And that key is a shared evidence infrastructure. We absolutely have to mandate tracking data by sex. We need to reframe our actuarial models so they stop confusing being female with systemic diagnostic delay. We need cross-specialty clinical hubs that treat root biological mechanisms, not just isolated symptoms. And we urgently need foundational research initiatives to actually understand female biology. This shared evidence infrastructure is what finally makes those invisible costs of diagnostic delay visible to everyone. And the payoff for finally doing this? It's monumental. Fixing this architectural flaw isn't just about, fairness or equity, though it is absolutely that. It is a massive economic mandate. Studies show that closing the women's health gap could generate $1 trillion in annual global value by the year 2040. For every single dollar invested in women's health, we could see $3 in economic growth. It's quite literally an untapped trillion-dollar market. As we wrap up this explainer today, I really want you to look at your own industry, whether you're in policy, clinical care, biotech, or finance, and ask yourself, which sector's decision holds the power to unlock yours? Are you just going to keep waiting around for the data, or will you take the lead in redesigning a healthcare architecture that finally works for everyone? The blueprint is right in front of us. Now it's time to build it.